my name is Alexander Sherry. I am a third-year medical student at Vanderbilt University, and today I'll be sharing with you some basic principles of palliative radiotherapy. I invite you to first reflect back on the last patient you cared for who had advanced malignancy. In your care of this patient, how often did you consider local disease as the etiology of their most important symptoms and largest complaints? If this patient were a candidate for palliative radiotherapy, would you have felt confident referring them to discuss palliative radiation to treat their symptoms? First, we should ask the question, why does palliative radiation matter? Why is this topic relevant for providers? Most importantly, cancer affects patients of all ages and in all settings. However, cancer is an especially critical diagnosis for providers who care for the elderly, since cancer is a geriatric disease, and the number of elderly patients afflicted with cancer is growing. In a 2010 study in the Journal of Clinical Oncology, Smith and colleagues projected that the burden of cancer will increase, but most prominently in the elderly population. As shown by this graph, by 2040, the proportion of patients over 75 with malignancy, shown here in the purple and blue curves at the top of the graph, will be significantly greater than what we see today. Based on these data, it is especially significant for providers who care for elderly patients to be aware of palliative radiotherapy, its indications, and when to refer patients for treatment. That being said, what is palliative radiation? In short, palliative radiation is a non-invasive, non-pharmacologic means of achieving effective symptom control of local oncologic disease. Palliative radiation is typically delivered in the form of X-rays by a device called a linear accelerator shown here on the left. As you can see, this device is positioned around the treatment table where the patient lies during therapy. Palliative radiation is a focal treatment. That is to say, it treats a local, focused area. In the CT scan on the right, the radiation dose to the targeted vertebral body is shown here in red, with lesser dose surrounding the vertebral body in blue, representing entrance and exit dose of the target. In this plan, other organs and structures in the region of the treatment target that are not shown with color do not receive an appreciable radiation dose. And this is important for understanding radiation as a predominantly local therapy. Now that we've discussed the definition of palliative radiation, which patients are good candidates? I like to think of indications for palliative radiation in 4 different buckets: brain metastases, cord compression, bony disease, and visceral disease, all of which are fairly common in our patient population. For example, the incidence of brain metastases is rising, with about 14 new patients diagnosed per 100,000 each year in the U.S. Cord compression appears in up to 10% of all cancer patients, and rapid diagnosis and treatment is critical to the preservation of function. Bone pain from metastatic disease is among the most common complaint of patients with disseminated cancer. And lastly, there are a select group of syndromes and presentations which can benefit from treatment with radiation, mostly for the alleviation of an obstruction due to mass effect. What patients qualify for palliative radiation? Where do patients come from who are receiving palliative radiation? In short, most everywhere. While many of us typically think of ambulatory patients visiting the clinic and returning home as the primary patient population receiving palliative radiation, patients who are admitted to the hospital or participating in rehab can also receive palliative radiation. Moreover, just because a patient is receiving hospice services does not prevent them from receiving palliative radiation. As cancer is the most common diagnosis leading to hospice, it is highly salient for hospice providers to be aware of palliative radiation as a measure of improving comfort and quality of life in the hospice population. Let's talk for a minute about the nuts and bolts of radiation. How long does radiation take? What are the steps needed in the treatment process? Well, the first step is a CT simulation scan. This scan maps the normal anatomy and tumor anatomy of the patient and is used to plan the radiation. The patient lies in the same position that they will be treated in. Some patients, such as those with head and neck tumors, may need a custom-made mask in order to ensure reproducibility of the treatment position and mitigate movement during treatment. Once the CT simulation is made, the radiation oncology team delineates the anatomy and sets up the radiation fields. For typical palliative cases, this step takes about 1 to 2 days. After this, the patient can begin treatment. Typically on a treatment day, the patient is asked to lie on the treatment table for about 15 minutes. During that time, the radiation is delivered for about 5 minutes. All in all, door-to-door time in the cancer clinic is about 30 to 45 minutes. Treatment is delivered once daily. The number of treatments a patient receives is dependent on the tumor and tumor characteristics, such as size and positioning next to other organs, as well as high-level evidence from phase 3 randomized controlled trials evaluating different treatment schemes. I like to think generally about the time course for palliative radiation in 3 major groups: 1-day treatments, 5-day treatments, and 10-day treatments. Treatment is typically Monday through Friday, so this translates to 1 day, 1 week, and 2 weeks. However, these paradigms are always evolving. For example, a phase 2 randomized clinical trial evaluating bone metastases was published the week prior to this video in April 2019 in JAMA Oncology by Wen and colleagues. This study demonstrated that 1 day of treatment with a special technique of radiation had the same durability of pain relief for patients with bone metastases as 10 days of treatment. While everything we've discussed so far is important, the ultimate question we need to reflect on for each patient is why. Why should this patient be considered for palliative radiation? Above all, palliative radiation assists the patient whose goals are symptom relief at one or more focal sites of disease. Most cases of palliative radiation will match this paradigm. There are other more specific rationales and indication for palliative radiation depending on disease site. For example, brain metastases are treated not only for patient comfort and quality of life, but also for improving disease control. Cord compressions are treated for the preservation of function, and bone metastases can be treated even to improve overall survival in certain circumstances. Most critically, however, and above all, palliative radiation is a successful, evidence-based, well-tolerated, time-efficient, and cost-effective intervention essential for the appropriate delivery of palliative oncology care. Thank you so much for your attention.